Data from the U.S. Renal Disease Service, USRDS, suggested that patients with chronic kidney disease, CKD, on hemodialysis, HD, are at higher cardiovascular disease, CVD, mortality risk compared with the general population. According to the data from a prospective cohort study, CVD is the most common cause of death in patients with CKD on HD, irrespective of race. Nearly half of the cause of death is due to CVD also in the Southeast Asian population. Given these data, it is suggested that it is most important to inhibit the development of CVD for the improvement of mortality in HD patients. Heart failure, which is one of the cardiovascular diseases, is caused by different factors, and one of these involves vascular calcification induced by mineral metabolism abnormalities, wherein there is an increase in serum calcium and phosphorus concentrations. If the elasticity of blood vessels decreases due to calcification, cardiac load increases, and this phenomenon is accompanied by decreased circulation in the coronary artery. As a result, congestive heart failure develops, which then increases the risk of death. It is clear that mineral abnormalities are associated with patients' mortality. Recently reported multi-center observational studies show that the risk of calcification in the aorta was 3.07 times higher in dialysis patients whose serum calcium concentration is greater than 9.5 milligrams per deciliter. Hypercalcemia is a risk factor that leads to a higher chance of developing aortic calcification when compared with instances where calcium phosphorus product is higher than 55 milligrams square per deciliter square, or serum phosphorus concentration is higher than 5.5 milligrams per deciliter. What happens to mineral homeostasis in CKD patients? In a healthy individual, serum calcium concentration is strictly controlled by the parathyroid hormone PTH. If serum calcium concentrations decrease, PTH is immediately released from the parathyroid gland to enhance the reabsorption of calcium in renal tubules, and to activate vitamin D, which enhances the absorption of calcium from the intestinal tract. In addition, bone resorption is also stimulated, and the mobilization of calcium from bone increases. Thus, PTH acts on the kidneys, intestines, and bone in response to decreased serum calcium concentrations in order to increase serum calcium concentrations. Conversely, PTH secretion is suppressed in response to increased serum calcium concentrations in order to decrease serum calcium concentrations. Serum calcium concentrations are maintained in a homeostatic state through this repeated cycle. However, this mechanism for homeostasis does not work well in hemodialysis patients. Because the renal function of dialysis patients is impaired, the kidneys of these patients will not be able to facilitate calcium reabsorption and vitamin D activation. Therefore, if serum calcium concentrations are reduced, the only way to increase calcium is by mobilizing calcium from the bone. As a result, it is more difficult for dialysis patients to regulate calcium through PTH, and bones are more likely to become brittle. If hyperphosphatemia, hypocalcemia, and decreased serum active vitamin D concentration are present, PTH secretion is enhanced and leads to the proliferation of parathyroid gland cells. This pathological condition is called secondary hyperparathyroidism. Excessive release of PTH in the blood increases bone resorption, which in turn mobilizes calcium and phosphorus in the blood. Thus, serum calcium and phosphorus levels increase easily. According to data published by the Japan Society for Dialysis Therapy in 2013, both hyperphosphatemia and hypercalcemia result in higher mortality risk. Both hyperphosphatemia and hypercalcemia are important factors that worsen the prognosis of dialysis patients. The progression of secondary hyperparathyroidism is just one of the causes of hypercalcemia. What more should we know? At the start of dialysis, patients usually begin taking calcium-containing phosphate binders and active vitamin D formulations. Active vitamin D has been used to prevent the progression of secondary hyperparathyroidism. Due to the expectation that active vitamin D has organ protection effects, this medication is considered indispensable for dialysis patients. However, active vitamin D enhances the absorption of calcium from the intestinal tract, and long-term treatment often leads to increased serum calcium concentrations. In addition, the use of calcium-containing phosphate binders also increases serum calcium concentrations because calcium within the drug is frequently absorbed by the intestine. This means that numerous cases of hypercalcemia may be caused by overdoses of active vitamin D and calcium-containing phosphate binders. It is time to think about the importance of calcium management and not to just focus on PTH and phosphate management. According to data from the Japanese Society for Dialysis Therapy, the number of patients with hypercalcemia increases with longer durations of dialysis. Around 20% of patients develop hypercalcemia if they undergo dialysis for longer than 10 years. How should we then manage serum calcium concentrations? For secondary hyperparathyroidism patients, because of excessive PTH secretion, bone resorption is enhanced and calcium is released into the blood. Cinacalcet was developed to suppress PTH secretion through a novel mechanism. Cinacalcet mimics calcium ions and acts on the calcium-sensing receptor on the transmembranes of parathyroid gland cells to suppress the secretion of PTH, which in turn suppresses calcium mobilization from the bone. Different from active vitamin D, cinacalcet does not stimulate absorption of calcium from the intestine. Thus, serum calcium concentrations can be decreased. With the use of active vitamin D monotherapy, serum calcium concentration increases easily and may lead to ectopic calcification within blood vessels. Combination use with cinacalcet is expected to be able to suppress vascular calcification because combined administration can suppress serum calcium concentrations. In a recently published large-scale clinical study, ADVANCE, combination therapy using cinacalcet and low-dose active vitamin D was proven to lower calcium levels and reduce calcification in the aortic and mitral valve. Cinacalcet plus low-dose active vitamin D not only controlled PTH and calcium to meet the CKD-MBD guideline, but also suppressed vascular calcification and is expected to improve patient treatment outcomes. How do we prevent hypercalcemia? Here, the relationship between PTH and serum calcium concentration is shown. For patients with secondary hyperparathyroidism, the set point for PTH calcium will shift to the right because the expression of calcium-sensing receptors is reduced due to hyperplasia. As hyperplasia progresses, the expression of calcium-sensing receptors is reduced and the sensitivity to calcium decreases. The set point will then shift further to the right. Higher calcium concentration levels are required to suppress PTH secretion. Moreover, PTH reactivity to the bone deteriorates, causing higher levels of PTH and calcium in dialysis patients. There are no symptoms for the progression of hyperplasia. If appropriate treatment is provided at an early stage, it may be possible to prevent hypercalcemia. From a survey in 2011, doctors were found to frequently stop administration of active vitamin D when serum calcium levels are over 10 milligrams per deciliter. However, it may be more effective to avoid hypercalcemia by reducing or stopping administration of vitamin D before serum calcium levels are beyond the upper target level, 10 milligrams per deciliter. In recent years, the importance of phosphate management has been advocated, and a review of the administration of drugs to manage serum calcium concentrations properly to improve quality of life and the survival prognosis of dialysis patients has become necessary.